Welcome to the Insurance Producers Guild, delivering intelligence for independent agents to help you stay ahead of the trends shaping Medicare, ACA, life insurance, and the broader insurance market landscape. Let's get started.
You walk the floor of any major insurance conference right now, and, well, you hear the exact same thing. You talk to agents who primarily sell Medicare Advantage, and they will tell you straight to your face that Medigap is completely dead.
Oh, completely. They think the market has just permanently moved on.
Right. They think anyone still talking about supplements is just, stuck in the past. But if you actually look at the raw numbers for 2026, we are staring at the biggest structural resurgence of Medicare supplements in a decade. Agents selling only Advantage plans are about to get left entirely behind.
Yeah, they are completely missing the reality here. Let's just dissolve that Advantage-only bias right now in the first 90 seconds. Look, Medicare Advantage out-of-pocket maximums are hitting $8,850.
Wow.
Meanwhile, Medigap persistency is sitting above 90%. And here is the real bombshell hook. The High-Deductible Plan G plus Hospital Indemnity combination delivers better protection than Standard Plan G at $36 less per month. This is not nostalgia. It is math.
It really is. And, I have been through this before. I have seen this exact market cycle play out. When you have been in this business for over 25 years, well, you learn to spot the patterns.
You definitely do.
So we want to translate these shifting numbers into actionable plays for your book of business, your clients, and frankly, your commission statements. Because right now we are seeing a measurable deterioration in Medicare Advantage plan quality.
Absolutely. The financial reality for a lot of members is just becoming incredibly stark. The Centers for Medicare and Medicaid Services recently confirmed the first measurable reduction in Advantage plan counts in several years.
Yeah, that was a big deal.
It was. We are seeing multiple national carriers actively consolidating their product portfolios. They are pulling out of counties where they are only marginally profitable.
Right.
And that leaves beneficiaries with fewer plan choices and much narrower provider networks.
And we should be clear about that. You should never look at carrier consolidation as a negative thing. It is strictly an opportunity for you to review your contracts, check your rate competitiveness, and look for underwriting flexibility.
That is a great point. There are regional and niche carriers gaining serious market share right now with competitive options.
Yeah, exactly. But from the client's perspective, this consolidation is painful. I mean, the average medical maximum out-of-pocket limits increased from roughly $5,100 to $5,440.
And that is just the average. Like we just said, those maximums are actually reaching $8,850 for in-network services alone in many markets. And that is strictly the medical side.
Right. Part D is a whole other story.
Yeah. Part D deductibles jump from roughly $230 up to $375 for most enrollees.
Plus, we're seeing a huge drop in all those flashy extras that agents have loved selling for the past 5 years. Those non-Medicare supplemental benefits, well, they have dropped by $7 per member per month on average.
Which is huge.
It is. Zero premium plan availability actually declined by 9.5%. You can see the shift happening right at the kitchen table.
It is a complete reversal in consumer sentiment. For a long time, beneficiaries were drawn to the ancillary perks. They wanted the vision coverage, the over-the-counter grocery cards, the free gym memberships.
Oh, everybody wanted the free gym membership.
Right. But now consumer priorities are shifting back to the core elements of actual health care. They are realizing that a free gym membership is completely useless when they cannot afford the copay to see a specialist. Or worse, when their primary care doctor is suddenly dropped from the network.
Exactly. We have all had that frantic phone call where your client is standing at the doctor's front desk and they have just been told their network changed.
It is the worst call you can get.
It really is. That is the exact moment that $50 grocery card means absolutely nothing. I sold Medigap before MA existed. The clients who stayed with it never had a bad year.
That statement right there is backed up by the numbers. When we say persistency rates in MedSup blocks are exceeding 90%, what we mean is that these clients buy the policy and they stay put.
Because they have standardized, predictable coverage.
Exactly. They are not exposed to the annual volatility of Advantage contracts, which, constantly fluctuate based on carrier bid negotiations and federal star rating incentives. That stability translates to incredibly high member satisfaction.
And predictable commission income for your agency. The real question is how you monetize this consumer anxiety today. Clients are feeling the pinch of these rising out-of-pocket costs, and you need to step in and solve that problem.
Here's what I say. Your MA plan's out-of-pocket max just went up again. Let me show you what a supplement would actually cost you versus what you're currently risking.
I love how direct that is. It addresses the immediate pain point without overcomplicating the pitch.
Keep it simple.
Right. And if you are working with PSM brokerage, you already know that agents have access to MedSup contracting across top-tier carriers. You should absolutely talk to your PSM rep about your current portfolio to make sure you have the right products loaded up for these reviews.
That is a critical step.
Yeah.
Because the product landscape is shifting fast.
Okay, but I need to stop you there and push back on the strategy for a second. I love the idea of moving clients back to Medigap. But we both know the reality of the market right now.
The premiums.
Exactly. Standard Plan G premiums are rising fast. We are seeing 20% increases in many states. A Standard Plan G for a 65-year-old is hitting $128 or more every single month.
Yeah, it is getting up there.
So how are you actually going to sell a $128 monthly premium to a fixed-income senior who is used to a zero premium Advantage plan? I mean, they're going to laugh you out of the house.
Well, that is exactly why you have to change the strategy. You cannot just blindly pitch a Standard Plan G anymore. The High-Deductible Plan G plus a stacked hospital indemnity combination is the most compelling product development in the market right now.
Really?
Oh, absolutely. It completely solves that premium objection.
Explain that to me, because the moment you pitch a high-deductible anything, seniors immediately start to panic. The deductible for that plan is $2,870. You are hanging a nearly $3,000 risk right over their head.
Right, but you do not leave them exposed to that deductible. The High-Deductible Plan G gives you the exact same comprehensive coverage as a Standard Plan G, once that $2,870 deductible is met. But the monthly premiums drop drastically.
So how do you protect them before they hit the deductible?
To protect them from the deductible itself, you fill that specific gap with a hospital indemnity plan. Think of it like buying a highly reliable car with a high-deductible insurance policy for major wrecks, but then you buy a cheap, separate roadside assistance plan to handle all the daily flat tires and tow trucks.
Okay, that makes sense. Walk me through the actual numbers on this. I want to see how this combination mathematically beats a Standard Plan G.
Let me break down the exact math of this stack. You start with a high-deductible Plan G. In competitive markets, you're looking at rates as low as $44.24 per month.
Wow, that is low.
Very low. Then you add the hospital indemnity base plan. A solid base plan that pays $300 a day for a 6-day benefit period costs about $18.30 per month.
Okay.
Next, you stack on an outpatient surgery rider that pays a $500 lump sum. That is $13.26 per month.
So we are sitting around $75 a month so far. What else are you putting in this stack?
You add a cancer rider, which pays a $2,500 lump sum immediately upon diagnosis. That is just $4.47 per month.
Less than $5.
Exactly. Finally, you add a skilled nursing rider that pays $100 per day for up to 50 days. That rider costs $11.17 per month.
Let me make sure I have all these pieces. You have the high deductible plan, the hospital base, the surgery rider, the cancer rider, and the skilled nursing rider.
That is the complete stack.
So if you add all those premiums together, what is the total out of pocket for the client each month?
The total monthly cost for that package is $91.44. Now compare that to a Standard Plan G, which sits at $128.21 per month. By building this specific combination, you are saving the client $36.77 every single month.
That is huge for a fixed income.
It really is. That is $441 a year staying in their pocket, and they actually have more comprehensive coverage for hospitalization scenarios.
Let's test that out. I want to walk through a real-world claim scenario to prove that the math actually works when the client gets sick.
Let's do it.
Take a client who has a 3-day hospital stay, followed by 28 days of skilled nursing rehab. If that client just bought a Standard Plan G, they are paying $538 annually just in premiums.
Exactly. But with the high-deductible G plus hospital indemnity combo, their total out-of-pocket cost for that entire medical event drops to just $117.
Wait, how does it get that low? Break down the exact mechanics of that payout. When the client is actually dealing with the billing department, how does this function?
Well, the hospital indemnity policy steps in and pays out cash directly to the client. The money does not go to the doctor or the hospital. It goes straight into the client's bank account.
Oh, nice.
Right. So for the 3-day hospital stay, the base plan pays $300 a day, which is $900. For the 28-day rehab, the skilled nursing rider pays $100 a day, which is $2,800. So the indemnity policy hands the client a total cash payout of $3,700.
And the client takes that $3,700 cash and uses it to completely wipe out the $2,870 deductible on the high-deductible Plan G.
Precisely. The cash payout largely offsets the deductible, and they even have some money left over for other expenses. The client is completely financially protected. They save $441 in their monthly premiums throughout the year, and they are not stressed about a massive surprise bill arriving in the mail.
Agents who learn this math before everyone else does will have a real edge. This is a massive value add for the client.
Oh, absolutely.
And there's another layer to this that makes it a huge win for your agency's revenue. Hospital indemnity is guaranteed issue for ages 60 to 79 using simplified underwriting.
Yes, that simplified underwriting is key. It is just a short list of serious conditions. Clients cannot be denied for high blood pressure. They cannot be denied for well-managed diabetes without serious complications.
It's way easier.
Way easier. The approval process is incredibly smooth compared to full medical underwriting.
And from a pure business perspective, the commission angle is rock solid. We are seeing Medicare Advantage and even standard MedSup commissions getting squeezed in certain areas, but carrier commissions on hospital indemnity have remained completely stable.
They really have.
You earn more revenue per client while providing genuinely better value.
You just have to know how to pivot the conversation to make the risk feel tangible to the client. I use a very specific approach to open their eyes. Let me ask you something. What would it cost you if you had a 3-day hospital stay right now? Pause. Here's what most people do not know about their plan.
That slight pause is everything. You are forcing them to actually mentally calculate the thousands of dollars they are risking on their current Advantage plan. And again, you do not have to figure this out alone. PSM Brokerage has the exact contracting support you need for hospital indemnity and all these ancillary lines to help you build this exact stack. You can lean on their product specialist to find the most competitive riders in your specific zip code.
But, there's a massive clock ticking on all of this, which brings us to the most urgent part of this entire discussion. You cannot wait for a client to get sick to offer this high-deductible G combination.
No, you really cannot, because if you wait, you are going to hit a massive regulatory barrier. This is what we call the 90% problem.
It is a huge problem.
90% of Medicare Advantage enrollees ages 65 and older do not have guaranteed issue rights to purchase a Medigap policy if they decide to leave their Advantage plan outside of the initial 12-month trial period.
Right.
We are talking about 22.4 million people who might be permanently locked out of Medigap if they wait too long to make the switch.
A lot of clients assume they can just switch back to Medigap whenever they want during the annual enrollment period. But the federal guaranteed issue protections are incredibly narrow.
Very narrow.
They basically only apply if an Advantage plan completely terminates coverage in your specific area, or if you are still inside that first 12-month trial period, or if the Advantage plan commits actual fraud.
That is basically it.
Right. If your client does not fit into one of those tiny regulatory boxes, Medigap insurers can and will deny them based on their medical history.
And they absolutely do. You look at these insurer applications and the language is brutally clear.
Oh, it is.
We are talking about deniable conditions like Alzheimer's disease, asthma, cancer, congestive heart failure, diabetes with complications, end-stage renal disease, high blood pressure, stroke. Even just basic limitations of daily activities.
Yes, exactly.
They literally print on the form, if the client answers yes to any of these health questions, do not even submit the application.
And when you look at the prevalence data, the statistical urgency becomes undeniable. Among all Medicare beneficiaries, 67% have hypertension.
Wow.
Yeah. 26% have diabetes. 19% have chronic kidney disease. 12% have heart failure. 10% have prostate cancer.
Think about what those numbers actually mean for you as an agent sitting at a kitchen table. The vast majority of your long-term Advantage clients will be medically unqualifiable by the time they actually feel the pain of their network restrictions and ask you to switch them.
Yes. The conversation has to happen before the hospitalization, not after. Once common conditions like hypertension or diabetes progress into complications, they are permanently locked into the Advantage system.
Now, your geography plays a huge role in how you tackle this problem. State protections vary significantly, and those variations create specific opportunities for agents who know the local rules.
Right. Like there are 4 continuous guaranteed issue states, that is, Connecticut, Massachusetts, Maine, and New York. In those states, insurers have to offer continuous or annual guaranteed issue for all Medicare beneficiaries 65 and older, completely, regardless of their medical history.
And we are seeing legislative movement in other states to expand these rights. Minnesota, for example, is adding a new guaranteed issue window for beneficiaries ages 65 to 70.
Oh, that is right.
That new rule becomes effective August 1st, 2026, and it is a one-time use during the Medicare open enrollment period.
Then you have the 9 birthday rule states. That is California, Idaho, Illinois, Kentucky, Louisiana, Maryland, Nevada, Oklahoma, and Oregon.
Got it.
If you are an agent in one of those states, your existing Medigap holders are allowed to switch to an equal or lesser plan within 30 to 63 days of their birthday, depending on the state, without any medical underwriting.
If you are in a birthday rule state, you have a built-in recurring calendar for these reviews. Every month, you have a roster of clients you can call to improve their coverage. But if you are writing business everywhere else, you have to initiate this proactively. You have to build the evidence and have the conversation right now to protect your client's coverage and to protect your own book of business.
Because if you do not, someone else will. Or the client will get sick and be stuck blaming you for their out-of-pocket bills.
To understand where the specific targets are in your existing book, it helps to understand where the market is currently sitting. Right now, Plan G holds 39% of all Medigap enrollment. Plan N holds 10%.
And then you have the sleeping giant, which is Plan F. Plan F still holds 36% of the entire market. But remember, Plan F has been completely closed to anyone newly eligible for Medicare since January 1st, 2020.
That brings us to a really important strategic reality for you to consider right now. Together, Plan G, Plan F, and Plan N represent 85% of all Medigap enrollees. But look closely at that massive Plan F block.
It is massive.
It holds 36% of the market, but it is aging rapidly, and the pool is shrinking because absolutely no new healthy entrants can join the plan. Without new, healthy people coming in to offset the medical claims of the older members, those Plan F premiums are mathematically destined to climb significantly in the coming years.
Without a doubt.
So here's the question you need to ask yourself as an agency owner. Who is running CRM reports right now to re-engage those specific Plan F clients and move them to a high-deductible G option before a competing agent dials their number?
That is this episode of the Insurance Producers Guild. If you are not already with PSM Brokerage, this is the kind of product intelligence our agents get. Talk to us about contracting.